The very first speaker that we're going to hear from is Esther Dyson. Thank you so much for coming here, Esther. Esther's got a keynote prepared for us, and she's going to talk about a lot of things. She's had a really, really interesting story, and her current commitments are 100% focused on her most recent project called Way to Wellville, which she's going to introduce. And she told me that aside from the 100% of her time that she spends on that, she spends about 50% of her time sitting on boards, investing in companies and nourishing startups, including 23andMe. And so yeah, without further ado, thank you so much, Esther, and hope we're going to have a good keynote.
Good morning. So I'm coming here to talk about health, not health care. And I say this again and again, and people sort of seem to understand it, but then it kind of disappears. But the best way to reduce healthcare costs is not to reduce the prices of the care, but to reduce the need for it overall. And we actually know how to do that. Back to what Sir John said, you know, with absolutely no innovation, other than innovation in actually doing stuff, we could make the world so much healthier. It's nutrition, exercise. How many of you exercised this morning? Not too bad. How many of you had a healthy breakfast? No added sugar? We did. Thank you, Lucas. But I'm not going to lecture you about clean living. I'm first just going to give you a brief illustrated précis of how I got to where I am. Then we're going to do a Q&A/discussion around this concept, which is, you know, I love genetics. I'm on the board of 23andMe. My parents are both scientists. But at the same time, I studied economics. And we are spending so much money fixing things that shouldn't be broken in the first place. And that's the realization I came to once I figured this out. The arrows, let's see. Nope. Sorry. Technology. Okay, the down arrows. Great. Okay. Yeah. So, as I said, I'm not a boring, clean living proselytizer. I trained as a cosmonaut. This is me and two other members of the backup team in our training experience pretending we had landed in Siberia. We had to sleep outside for 2 nights. It was fun. But back sort of to business, I was a Wall Street analyst. I ran a conference, and I asked to be on the judging panel for the X Prize Foundation Healthcare X Prize, which never actually happened for managerial reasons. Not some interesting, specific scientific problem, but you know, there was actually a PDF, don't write this down, that said, for example, if you reduce heart attacks by 30% and diabetes by 20%, you've already got a 50% improvement. Anyway, it never happened. But I kept wondering about the idea, and I interviewed a very interesting guy who wrote a site called Real Age, which asks you about your behavior. Do you argue with your spouse? Do you have a dog? What do you eat? Do you get all the stuff I asked? Do you get exercise? Its business purpose is to sell vitamin supplements. He sold it to Hearst, which then sold it to ShareCare. But what was interesting, I found when I interviewed this guy, whose name was Charlie Silver, is who he sold his first business to. It was Jiffy Lube, which is a well-known car maintenance oil change outfit in the United States. And I thought, maintenance of cars. We actually do a better job of that than we do with bodies. So started thinking about that some more. And this is a very well-known, if not chart, concept. What matters to health is your daily life. It's what you have access to, it's your behavior, it's what your friends do. And then a very little bit, both depends on healthcare and on genetics. We spend the money 97% on healthcare, and in the United States at least, and also around the world, we're getting worse and worse outcomes, despite what John talked about. You know, all these great discoveries we've made. My sister, who John knows, had a double mastectomy a few years ago, and is fine. 40 years ago, she probably, you know, it would have been curtains. But at the same time, people are getting sicker and sicker, and whatever happens to you, whether it's breast cancer or dementia or an orthopedic operation or even giving birth, if you're healthy when you go in, you're more likely to be healthy when you come out. So I kept thinking about this and became a big fan of quantified self. I've got all these things and personal discipline. But I still kept thinking we really need a health X Prize. And I was about to say, someone should do a health X Prize. And I realized, I don't actually have a day job. So I started what at the time was called HICCUP, Health Initiative Coordinating Council, and asked friends to give me advice about what this should be. And I ended up hiring a CEO to help me make that happen. And he said, Esther, HICCUP is clever, but I'm not sure anybody really gets it. So it's now called The Way to Wellville. It's not a clinical trial, but it is 5 small communities, and in a sense, the rest of the United States is the control group. I decided to do The Way to Wellville in the US to limit the complexities to the problem at hand rather than dealing with the AAR in the UK and the great system they have in Finland and so forth. And we discovered that the communities didn't really want a contest. They wanted to learn from one another. So let me talk about the basic premise here. The idea is, if you change the environment around people, it's not just give them a Fitbit and tell them to behave. But if you make it easier for that to happen, if people have access to healthy food and it's convenient, if their neighbors are exercising, if their communities are livable, you can send your kids out to play without worrying that they're going to be shot or run over in the street. It's much easier to become healthy. And in the context of Brexit and Trump, we're mostly dealing with the 50% of the people who aren't being heard. And I'm just curious if anyone in here voted for Trump or Brexit. You know, everybody's laughing, but something like 50% of people did. And people like us often don't pay attention to that. So we're working with that other half. And what we wanted to do was find small communities where you get critical density. In other words, whatever interventions we do, and I'll get to what those are, they interact. Your kid gets a better diet at school, goes home, mom is in an exercise program, dad is getting mental health counseling to deal with his anger issues. It's real. Mental health is a big part of this. But all those things interact. And when you go to the grocery store, they have a special on vegetables instead of cupcakes. So critical density, in physics terms, that's what makes things explode. It's not actually the total mass, it's the density with which the mass is packed in. So we wanted small places, also because our resources are limited, we wanted them to be defined so that people wouldn't go somewhere else for lunch or go to work here and there, but everything in one place so you get this critical density interacting. And we put out a call for applications. This is now the summer of 2014, my CEO and I, throughout the US, and we got 42 communities that applied for fundamentally consulting help. We weren't giving them grants, and we weren't asking them to pay. We were kind of like a free personal trainer. It's your community, your programs, your people. When we leave, you will still own it, whatever it is, but we're going to give you advice on how to fundamentally improve the health of your community. The entities applying in each community had to be some kind of coalition of local leaders who had been working on improving health and wanted to up their game and actually have an impact. Because with one exception, and we turned them down because they were too good, there were all these nice, well-meaning people who had been trying to improve community health with almost no visible impact for many years. It's hard. It's not just giving out pamphlets or telling people to use a Fitbit or go to the gym. It really requires change. It's, as you said earlier, it's logistics and systems change. It's not innovation or inspiration. It's real work. So we got these 42. We visited 10 of them over the summer of 2014, and here they are. Actually, Niagara Falls is no longer in the group. We kept calling them to go to the gym at 5:30, and they never went. And so they got replaced with Hartford, Connecticut. Sorry for the slide, but anyway, 5 places. The idea was not the 5 very best, but rather, just as you might want in selecting a board or a group of people to go skiing with, you wanted the best group of 5 different places geographically, demographically, in terms of who the local institutions were, and these were the ones we picked. Now, you go into many of these places, and you talk to not the nice leaders who invited us in, but your kind of standard local person. Like, we don't need no stinking health care. I just need to get the car fixed. But you talk to those same people and you say, you don't actually say it, but you might have given up on your own life, but what about your kids? And that usually gets people's attention. If you want a woman to stop smoking, make her pregnant. It's amazing. That's sort of a joke. But this is who it's really for. And it began as a 5-year project. It's now a 10-year project. So by 2024, evidence, whatever, and I'll get to what the evidence is supposed to do. This is just me looking at a school lunch in Clatsop County. I like the photo. So what are we doing? We're doing these various programs, but we want these communities. I'm not trying to fix 5 communities. I'm trying to use these 5 communities to show what happens when you apply not just common sense, but vigor and accountability and planning and budgeting and implementation, and use that evidence to whoever is in office 4 years from now, help foster public understanding of the value of investing upfront in health to reduce the need and to increase the effectiveness of health care over the long run. We're also going to be reaching out to food companies. So every food company now has some kind of secret little kitchen or startup innovation lab or something where they're trying to figure out how to make the healthy food taste good. It's really hard. And what works in the lab may or may not work in the real world. We want to work with these food companies rather than demonize them. At one of our brainstorming meetings, we actually had a guy from the McDonald's Innovation Group, and he said, come back to me when you're ready. So if we don't have the food companies as part of the solution, we're not going to get to a solution. They have the distribution, the money, the marketing, the power. So it's important to help them figure this out. At the same time, we probably need to tax sugar, but we need to tax it for all of them, and then they can work together, they can live with it. One of the things I learned, so who recognizes HAI, hospital-acquired infection? Okay, there's also, especially in the United States, jail-acquired insolvency. It's a huge problem in that same part of the world where the white people vote for Trump and the black people go to jail. And that's a gross generalization, but it's half the kids born in the US right now are eligible for Medicaid, which is the government-funded health care provided to people with low incomes. And these people are predictably unlucky, not because of their genes, but because of where they live and what their parents did. And if you get into jail, then you come out and you can't get a job. So all these things put you into the hole. Poor health, both mental and physical, is only part of it, but all these things need to go right for you to climb out. And there are trade-offs around what do you invest in. It's not easy. And even though I can prove to you, and everybody who looks at the economics of it knows that the returns to investing in health are huge, the problem is that those returns are distant in time and they go from one bucket to another. It's not like you invest in health and you get the benefits back. An individual may invest in their health, their employer gets some benefit, their family gets some benefit, but they may not see the financial return, especially if they're not even paying for their health care. An employer invests in keeping employees healthy, but 3 years later, they're working for another employer. So figuring out the financial mechanisms by which this works is challenging, and honestly, the simplest way is for the government to pay more attention to community services, facilities, and again, probably to take some of the externalities of sugar and processed food, put those into the price of the food, i.e. tax it, and then take that money and use it for everything from educational facilities to paying health coaches and so forth. So, standard financial instruments, social impact bonds, but most of what's needed is long-term thinking. And then finally, what we're doing is we're not simply going to measure everything in 2024. We are working in real time to see what works, what doesn't. When McDonald's opens a restaurant, it's not experimenting. It's doing something it knows how to do. Not every restaurant is successful. Then they go fix it. So they learn on the way. And that's really what we're doing in these communities. We're helping them do what they know they want to do. We're helping them understand that they need budgets and plans. And good health is not charity. Good health is not well-meaning. Good health is, it's not quite industrial, but it's a bit like farming. You need to create the right conditions, you need to provide the right nutrients, and then the plants or the healthy people will grow by themselves. So, I've probably left a lot of questions, which was the purpose, and we can now move on to the fun part. Did somebody? So if somebody has questions, I'll answer them. If not, I'll think of some questions myself, because I have a few written down here. Okay, and for everybody's benefit, if you can say who you are so that by the end of the 2 days, everyone will know everybody.
Hi, I'm Jishan, Alberta in 2006 for the Rhodes parlance. So you mentioned like a lot of incumbents and how they're changing. So I've noticed that in the last few years, the automobile industry has woken up to self-driving cars, and they're making investments, and they're buying up startups, and they're trying to collaborate with others. Do you see the same thing, largely in like pharmaceutical companies and health systems, waking up to the fact that there's disruption coming, and they need to be involved in it, or are we still waiting for that same period of time with the incumbents?
That there's a what?
That the waking up to the fact that people are going to be buying less. Like the automotive industry is waking up to the fact that people are going to buy less cars, that self-driving cars are coming, that there's the change coming. Do you see the same thing with pharmaceutical companies around not just selling for disease, selling for treatment of disease, but prevention?
I'll try, yeah. So, I mean, pharma companies they're going to do fine. Their biggest challenge is, as you apply precision medicine, take a standard drug. It's, they say it's 60% effective in our clinical trials. Well, it's probably 98% effective for some set of people. It's downright toxic for 5%, and for the others, it has no impact. So, ironically, in theory, they should start charging more for it. And there are some drug companies that are now experimenting with, we're going to charge you only if we actually cure your disease or reduce your symptoms. Other pharmas are getting into things like adherence. It's great to sell the drug, but it only works if the people take it regularly. So the pharmas are experimenting with different business models. At the same time, so let's be clear. The opioid epidemic in the United States was mostly due to the efforts of Purdue Pharmaceuticals to sell its painkillers, even though it knew that they were addictive. Not all pharma companies are evil, but the incentives need to change, and they're starting to change with this focus more on outcomes. Drug companies are still more interested in their own drug being successful versus maybe everybody being happy. But the marketplace and also big data, not big data around genetics, but big data around outcomes and post-marketing surveillance. It used to be once your drug was being sold, there really was no way of knowing what was happening or whether it was effective. Now that's changing. So yeah, things are changing. The pharmas are recognizing it. That doesn't mean that it has permeated the system yet, but it's definitely happening.
Thanks. I'm Simon Hendry. I'm from Discovery Vitality, which is an incentivized health promotion program. My question's just, it's kind of 5 years in or maybe more than 5. And what kind of results are you seeing in these communities relative to the control? Like what kind of metrics are improving?
Yeah. Actually, it's 2 years in. Okay. 20. And to be very candid, we're not seeing very many results in people's health. It's way early. We're just getting to the point where the institutions are beginning to understand that they need to allocate budgets, that volunteers don't work. They need to, if you're going to launch these programs, you need to train coaches to deliver them. You need to go raise grants for the kinds of things you're doing. The one thing I would say in our defense, we did part ways with Niagara Falls. The point of that is not that they're bad, but that the other 4 communities in North Hartford that's joined, they are making progress even though it's not visible. It's kind of like a startup that, you spend a year or 2 just assembling the team, figuring out what you're doing, and your product. Most of this hasn't really launched yet. It's going to be slow, and that's kind of frustrating, as you can imagine. But nothing's going to work unless as I said earlier, it's not about you have a blinding idea and suddenly everything changes. You have to change the system that's going to start changing the processes. I went to a conference called School Food Focus, which is about school food, and I thought it would be, the little children and the nice white ladies and serving the lunch and health, and it was about logistics and procurement and buying insurance when you had people chopping vegetables with knives, and how do you change the schedule so the children have enough time to eat. It's really changing the environment is a lot of logistics. It's just like trying to change the processes in a hospital. The doctors are used to doing it one way and you have to start doing it another. You have to get people in the healthcare system to start referring their patients out to whether it's housing programs or counseling programs or gym memberships. And doctors are busy, they don't always think of that. So it's changing these kinds of processes. And that's why it's a nonprofit. It's why we haven't been able to raise any serious money from outside yet, because it's very long and slow. But we're seeing the internal kinds of changes that make us feel confident it's going to happen. John Bell.
Thanks, Esther. That was great. Two points. One is the Oxford Health Alliance here started one of these 10 years ago. So there's quite a lot of data, not in the US, but globally. So they had 5 sites. It's called Community Interventions for Health. It was all done on a Pepsi-Cola grant. And they had some very striking, it's very difficult to get outcome data, same problem. Your outcome data is very hard. But all the intermediate, body weight, smoking frequency, all that stuff, you can really improve the numbers. And again, it was the same philosophy. Get communities to do it, don't try and if they don't do it, it's not going to happen. Let me tell you what the problem was. The problem was that at some level, nobody cares. The community itself cares, but I can tell you to get that work published was like pulling teeth.
Yeah.
Nobody wanted to sit. They said, well, actually, it's a community intervention study, and you didn't quite have the right controls, and yet the observations were pretty barn door. So, in a sense, there's a problem with the healthcare community, and that is that they don't get it.
Yeah.
Because I think this is going to be really fundamental in terms of public health. But the second real question, rather than an observation, is that in the Brexit arena, in my view, the most important thing here is the inequalities of health. So you know the story that as you get on the Jubilee line, for every stop you take going into East London, life expectancy gets worse by a year. And so it's the real problem is how do you get to disadvantaged populations? Because they're the ones where you need the biggest uplift. Because the truth is, people like us, we're going to exercise anyway.
No, and if you're unhealthy, it's your own fault.
Exactly. So and I think that's the hardest nut to crack, and nobody's worked out how to do it. But you must have some thoughts on that.
Well, so if you ask for a place that's under 100,000 people, that's geographically defined in the United States, with the exception of maybe Aspen and all the places on the coast, every single one of these places used to be something else. Clatsop County used to be a fishing and lumber town with a lot of tourism. Lake County had a beautiful resort that was owned by the Plumbers and Pipefitters Union and got shut down because of an embezzlement scandal. And the people who used to come from San Francisco up to Lake County in the summer now fly to Hawaii for $200. Muskegon, Michigan, a small kind of manufacturing town in Michigan, another like Detroit. All those people somehow, they didn't vanish, they just lost their jobs and stayed and got poorer and poorer relatively. Spartanburg was textiles, and North Hartford is just honestly an urban slum. But they're not unusual. That's the scary thing. They do, however, they have a nice thin veneer of well-meaning rich folks who are mostly the people we're dealing with, and then an underclass of people who, as I said, were born unlucky. And those are the ones we are going after. And we're not going after them again with pamphlets, we're going after them with, so what matters to you? And health is different from health care. It's not just about your body mass index. It's about your environment. It's about your housing. It's about we're working with the jail in Spartanburg. When you get let out of jail, do you have access to health care and to counseling and to support? Do you have access to job reentry programs, stuff like that? So, for the American environment especially, a lot of what we're doing you might call poverty reduction, but health cultivation sells better. And they really fit together. You can't have one without the other. Yeah, or whoever the mic people choose.
Thank
My name is William Altman, and I grew up in rural Texas, sort of a hillbilly elegy sort of community. And you refer to the fact that, you know, you see a breakdown of the family and you've got so many illegitimate children that are being raised by single parents. And it seems like that is a huge obstacle to improving public health. And with a 10-year program, it would seem you may have an opportunity to even address that type of issue, because I remember my economics professor at Oxford said, you know, that there's a relatively simple, you know, solution to poverty, which is finish high school and don't have a child until you're married. And that, you know, people that do that are invariably usually not poor and usually in sort of middle income. So are you thinking of addressing that sort of problem and sort of helping the cultural aspects and the values-oriented aspects of your communities?
Yeah, if you look at sort of the mechanisms, there's a whole bunch of, quote, programs. There's something called the Diabetes Prevention Program, which also exists in a lot of permutations. There's a company called Omada that I'm an investor in that I need to put an asterisk in front of when I mention it in this context, because I'm not trying to promote my own companies. There's Noom, there's Canary Health. On the prenatal side, there's something called the Nurse Family Partnership. This is all US-centric, forgive me, which gets a 17 times return, according to Peter Orsag, who worked in the US Office of Management Budget. It's not for profit. What we're trying to do ultimately is use these programs with locally trained and sourced people and get them to scale. Because in each of our communities, there's all these nice people, but there's no quality control, there's no deliverables, you want to say something and I'll keep going. Yeah. Right. Yes. Yeah, these. Yeah. That would have a huge impact along with some of the other stuff. If you can't get the healthy food, you need to be able to get the education. I was going to mention there's another similar program called Parenting Journey, where you help the parents who may be 18-year-olds or 24-year-olds themselves to be better parents to stop that cycle. So, yeah, these are the kinds of things I'm talking about. We're not that focused on the old people who, quote, cost so much. Because one way or another, the healthcare system is worried about and dealing with them. We're really trying to figure out how to make the next generation fundamentally different. And you know, it depends on your community what kind of preaching you want. And we're not selecting the programs. We're helping them find programs that will deal with the problems that they identify to us. But as I said, Parenting Journey, Nurse Family Partnership, diabetes prevention, mental health are all part of what we see as key. Agnes from Rwanda.
Thank you very much, and I appreciate your presentation. There is a big issue here in the developing world. We all want to be a mid-income country. And in the other hand, we should not do for communities, without informing and make them demand for good health and good prevention. However, what is a mid-income country? It's a good car, a nice house, and an hamburger ships every day.
And what?
An hamburger.
Hamburger and chips with everything.
Every
yes.
day, as a symbol of progress.
Yeah.
And this is all over the world. And when we try to convince our communities, don't eat that, especially with Coca-Cola, they just look at you and say, you don't want me to progress.
Yeah.
So we have a lot of work to do, because the epidemic of obesity that has happened in America, and we all know where it comes from, is invading the developing world
Right.
as the progress is there. So, something to innovate there.
I'm very aware of this. And you know, whether it's Africa, Saudi Arabia, Europe, as an American, I'm not going to go around and preach to other countries. But there is one issue, which is when, like, the tobacco companies have now kind of given up in the US and they're redoubling their efforts in the rest of the world, and that really bothers me. I suspect, I mean, in some sense, Coca-Cola et al. Are doing the same thing. What I'm doing, I would love to inform the world. I don't, you know, I'm focusing on the US because that's where I have a voice, where I know the press. The whole purpose of Way to Wellville is for other people to copy us, and to copy us for their own conditions, their own culture, their own understanding, and at the same time to change the financial dynamics around the externalities of food costs within the US tax system, and then hope that other people will do the same thing. I don't feel I really have the standing to go to Rwanda and tell them what to do. But if anybody from Rwanda asks me, I'm happy to talk to them.
Thank you, Esther, for your talk. My name is Dylan Collins, a 2014 scholar from British Columbia, and I'm reading a DPhil in primary healthcare. My question for you is if you've thought about what death would be like in Wellville, in that unusual things can happen when you prevent disease. You know, everyone will die, so if you prevent certain diseases, they can live to get other ones, which could be more expensive, more painful, these sorts of things. We've seen that early when smoking rates declined, heart attacks actually went up because people weren't dying of lung cancer
Right.
but living to heart attacks. I'm just wondering if you sort of contextualize some of those things, or maybe if you're measuring any unintended consequences in these communities.
How shall I say? First of all, again, if you're healthy, almost inevitably, whatever the bad thing that shows up that kills you, when that comes along, you will be able to deal with it better. There's lots of discussion going on now about, you know, are we unnecessarily prolonging life? And I think in many, many cases we are. That's not where we are focused. I mean, if I had my personal Wellville, people would die painlessly with the right amount of morphine in their own beds at home, surrounded by their families. It's less of our focus because we can't do everything, and we don't want to spread what we're doing too thin. But the premise that death itself needs to be painful is something I would fight against. You know, we've made many deaths painful because of how we struggle to keep people alive who are barely able to deal with it. I mean, personally, I have double chance of Alzheimer's, and if it happens, I'm going to try and figure out how to gracefully commit suicide before it's too late. Yeah, not before I lose all my functions, but that's my personal decision. So honestly, I'm going to punt on your question to say that it's not our area of focus. I think it's an important area, you know, and I'm only one person doing one little thing, and there are lots of other people doing other things. But our goal is to extend healthy life, not to extend life at all costs. I mean, to me, life expectancy isn't as interesting as how healthy are you until the end. And I mean, there's health-adjusted life years. There are people who deal with metrics like that. So I would say that's more important. Somebody.
I've got a mic. My name's Andy. I invest money for Oxford Sciences Innovation. You were talking about some of the sort of economic changes in the communities that you're working in. You know, the loss of manufacturing jobs, the loss of fishing jobs. And I'm really curious about to what extent we can change with healthcare intervention levers some of these fundamental economic shifts.
Yeah.
You know, when people don't have jobs, when they don't have money, they might lose some of the motivations that if they were there, we wouldn't even have a problem to answer.
Right. Absolutely. As I mentioned, we want to train local health coaches. And in extremis, if 1/3 of the population in these communities is engaged in keeping 2/3 healthy, that's great. And nobody has 33% unemployment anyway. So in my other life, that other 50%, I spend a lot of time on self-driving cars and tech and, are we going to automate all the jobs? Health coaches who are local people, they're influencers, they're gym teachers, they're early childhood education people, they're doulas for pregnant women. There's a lot of jobs keeping other people healthy. And then healthy people are better employees. They're also better customers because they're not spending all their stuff either anesthetizing themselves with drugs or with problems of various kinds. They don't turn to crime to support their drug habits. So there's a lot of health measures, but what I really want to see in 2024, when I walk into one of these Wellvilles and knock on the door of a realtor, the realtor's going to say, I'm sorry, we're too busy, housing prices are up, everybody wants to move into town, the schools here are good, this is where people want to raise their kids, employers are coming in because they're opening call centers here because the people come to work on time and they're happy and engaged because life is good and normal. So it's that, and that comes from a community where, yes, people are employed, but they don't need to be employed building robots or designing software. Some of them may code, but many of them will be engaged for pay in making their communities a healthier place to live. And the problem with this whole thing, the cost of healthcare wouldn't be so bad if people were healthy. The problem is people are unhealthy, and it's still costing us that much. So my goal, as I said, is to reduce the need for healthcare rather than really, I don't care about the cost, it increases the GNP. The woman with the blonde hair on top.
I don't know. Anyway, hi, my name's Alex. I'm a doctor from South Africa. I'm currently doing a DPhil in neuroscience. I just wanted to ask in that sometimes, particularly with these sorts of interventions, the intervention that's got the greatest return on investment in terms of whatever your outcome is, but particularly when it comes to long-term health and that, isn't necessarily the sexiest intervention or the one that everyone's talking about. And yet, for an intervention to succeed, it needs to be something that the community has got great buy-in and are very interested in. How do you kind of balance that in terms of selecting which interventions your guys' model is going to focus on?
As I said, we don't select the interventions, they do. But I'm well aware. I talked to a guy from the US government who was trying to make our fighting forces more fit, and genetics, and could we select people for certain characteristics, not with breeding, but at least as we recruited them. And I said, you could actually do a much better job simply by feeding them properly. And he said, but genetics is so much more interesting. I guess the first thing is no intervention works on its own. It's got to be a combination. And anybody here in the advertising business? Funny thing. They now do a huge amount of big data to figure out why did I buy this striped thing? Was it because I searched for it on Google and then I saw it in a shop, or was it being worn by some woman on a YouTube video and then it was advertised to me when I was reading the New York Times? And finally, maybe 8 or 9 different things made me finally buy that thing. In the same way, cultivating health requires a lot of multiple interventions. Any intervention reaches a point of diminishing returns. And we're working with people who do really interesting metabolic models about all these interactions and what the actual numbers are, but it's not a single thing. And I mean, the other thing is, yeah, you could calculate mathematically what was the ideal little precision model of what would work in a community, and that's unrealistic. But you know, healthier food, fewer drugs, more mental health, counseling, they all work together. And we're not trying to reach perfection. Because, as you said, everybody's going to die in the end. The challenge is how do you make it a little better until they do? So we're not trying to optimize. We're just trying to make a difference big enough that you can see it.
Hi, thanks for your talk. I'm Stefania Marcoli. I'm a designer. So I'm not a scholar, a student. I met Dylan a few years ago, and then we started to do some little project, and I work a lot in chronic disease prevention. I have a question, because I found really interesting what you said, that you put the seeds, and then it's the community that essentially has almost to design its own solution and scale it. And then you said the outcome will come on the long term. Are you thinking in some way to measure having some subjective measurement from the community? Not because you wanted to measure that, but because it can be a positive feedback loop. Because I've studied a lot behavioral change theory and how much the self-perception of yourself is important. So our health is not only our body, it's our mind. And knowing that I am a better parent, that I care, and there are other people that care for me, it's already for me a result. And for me, I want to have a better quality of life also now, not that that's the thinking that I found interesting. It's really about when you can help people in understanding that having a better health can be also positive. It's maybe a local food is better, more tasty than an hamburger. That's kind of things, I mean, yeah. I'm just a very simple thing. So my question is, have you set up in your pseudo-clinical trial some subjective measurement or psychologist or way to start gauging how it's going?
So there's really 3 levels. There are, if you decide to run a diabetes prevention program, you measure those individuals that are members of the program and you chart their progress. Using BMI, did they actually transition to diabetes? Were you able to reverse the onset of diabetes? Various kinds of clinical measures. And the vendor of the diabetes program obviously cares a lot about that, as does whatever entity is paying for the program. Then, and our hope is, again, that this program will be more effective because around it will be other affordances and programs and changes in the environment, including what your friends are doing, that will make that program more effective. Then there's going to be the things, the community's particular goals, whatever it is that the community leaders decided that they wanted to measure. And some of them are specifically measuring, they're doing kind of opinion polls or surveys about people's pride in their communities and stuff like that. When we started, this talk was titled What I've Learned So Far. So when we started, we were going to have some very specific metrics that we would agree on with the 5 communities, and those would be kind of the most important thing. Should they be composite measures or kind of indicative measures like high school graduation rates or teen pregnancies or heart attacks or transitions to diabetes? And we went around and around and we didn't really get anywhere. And then we got really lucky. There's an outfit in the United States, it's called the Institute for Healthcare Improvement. It has funding from all kinds of research universities, billionaires, medical institutions. It's got partners, I think, like the Mayo Clinic. It's run by Don Berwick. It is about as establishment and respected and academically rigorous and everything as you can imagine. And they have this 100 million healthier lives program. So we said, we'll have what they're having. And that actually avoids the problem of, oh, well, did you pick metrics that you knew you could reach? And what we're betting on is that whatever we do, if people are healthier and happier and some of these other things they're employed, we're going to do better on the metrics that 100 million healthier lives picks. And ironically, they haven't quite finished figuring out what they are, but we've got 10 years. So that's how it's going to work. And I mean, we're going to invite researchers who want to do studies to come in and study whatever they think might be interesting, though at the same time, we don't want our populations to be specimens. You know, they have to invite these researchers in. Just shout it out. You don't have the mic, but. Yes. Yeah. 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 Right. We're working with state Medicaid organizations, not necessarily on prizes, but in Clatsop County, Oregon, the partner that brought us in is Care Oregon, which is the Medicaid plan in Oregon, which runs it somewhat differently. In Michigan, there's something called the State Innovation Model. Yeah, in many cases, the funding for us is kind of these special one-off, they call them Medicaid waivers. What we're trying to do is show that these Medicaid waivers actually produce such good results that instead of being Medicaid waivers, they should be Medicaid standards. But the governments, the healthcare systems, the philanthropists, we're working with whoever we can find that's interested. Yeah, right. So there's apps, there's games, there's protocols. All these things work if people do them. Our challenge is to get people to do them at scale. Yeah. That would make your chance of success. Okay. Are there intentional subcommunities that we could create, or that we could, latent communities that we could, yeah, I mean, in each of these communities, there are already subcommunities. There are churches, there are groups of various kinds, there are communities. And there's, in Muskegon, there's the community of Muskegon Heights, which has a really great mayor, and that's a subset. Yeah, people don't live in clumps of 90,000 people. They live in much smaller groups. And those are, if you like, those are the vectors of influence. And they are also, you know, there are communities that are most troubled, that there's a higher return for the people at the very bottom of the pyramid. And that's, you know, there's a lot of, well, if those guys can do that, we can too. So the Clatsop County people are doing trauma-informed care, and now the Spartanburg people are learning from them. And so that's, yeah, it's very, the basic idea is very simple and very broad, but the instantiations are very local and specific, but at the same time, people want to learn from one another.
Hi, my name is Richard. I'm in Trinity 2016, and I'm reading an MSc in Population Health. So a lot of the problems that you've talked today regarding health versus healthcare have to do with social determinants of health. And I think the work that you've done with incarcerated populations and school nutrition is fantastic. But a lot of these problems that disadvantaged communities face are a result of a history of policies that have limited access to education, transportation, housing, contributed to the school-to-prison pipeline, you know, broader systemic issues. And I'm wondering, given your experiences, what have been your challenges and limitations working in a nonprofit context to deal with these issues, and to what extent are you working with local and state municipalities to affect policy in this realm?
So you can't not work with local and state municipalities and officials. We're going to have an easier time changing policies once we've shown what changes happen with kind of simulated policies. So a simulated policy is where you get somebody to provide discounts on fruits and vegetables, whether it's food stamp dollars or somebody persuading a grocery that they should do that because they're going to get more business. So in a sense, we're simulating some of these policies to show their impact. To the extent we can make changes, that's great. Our communities are small and they're not, nobody came to visit these places. Omada Health didn't call on Muskegon. And so we're trying to up their game and up their ability to get access to some of these resources. But yeah, there's zoning rules around tobacco use that you can do locally. Some of the stuff mostly involving money, it's much harder. It has to be done at a state level. But that's definitely part of both the plan for funding what we're doing and then the plan for how we hope policies will change over time on the basis of what we're doing. And as John said, the challenge is, it's not just to do this, it's then to get people to pay attention. And that's another reason I'm doing it in the United States. I'm better connected, no political, and I am part of that elite. But I'm trying to use that to get them to pay attention to the people who are not. Okay, you know what? We have 3 minutes left, so let's have all 3 questions quickly, and then I'll do a little pirouette.
Hi, my name is Adia Benson. I'm an anthropologist, and so my question may sound more like a comment than one that leads to an answerable question. But my, I know I'm apologizing for my discipline in advance. One of the things that I'm struck by, and I apologize because I did not hear the entire presentation, but what I'm hearing from the questions and your responses is that communities are empowered by the directive to, I guess, come up with their own interventions and also to define their own problems. And one of the things that I've learned over almost 15 years of working in public health throughout the world is that, you're talking about communities have had a labor devaluing in their communities, right? I think you were talking about Spartanburg, South Carolina, and different places like that. And so I guess the question is about neoliberalism, which is, to what extent does this empowerment really just sort of shift the labor to individuals who are already experiencing a devaluing of their labor, when you're talking about something like a social determinant of health and policy. So do you get what I'm saying here? Like, essentially you're asking people who already don't have a lot of work to do the work of changing their communities, which in some ways...
What I was saying was they need to be paid.
It's not, that's what I guess what I'm trying to say. Okay.
No, I don't think it's our job to come in and change the community. It's our job to help the community change itself. I don't see that as forcing the labor on them. I see it as empowering them.
Okay, I didn't finish my question, but that's okay. I'd rather not. I'll pass.
Let's talk at lunch because we're trying to get 3 questions done in half a minute.
So, quick question for you. You're a very successful businesswoman, understand business incentives really well, and you're working in the nonprofit space in public health. And so, I guess the question that I have for you is, can traditional market incentives actually incentivize the public good of public preventive health?
Great, thanks.
Sophie, most recently from Wired magazine. I'm interested in the kind of lobby question. I remember that Hampton Creek Foods got death threats from the egg lobby when it tried to create mayonnaise that wasn't made with eggs. Kind of just interested in how you're looking at that lobby part, particularly from the food perspective, because it just seems to be such an difficult, intractable problem.
In a sense, those are the same question. The free market won't. The market with externalities recognized, with the WHO saying we should subsidize vegetables and tax sugar. Fortunately, we're not alone. We're part of a much greater movement and greater scientific understanding of the long-term impact of these things. But no, I think externalities need to be priced in, and then you'll get a return for investing long-term. But right now, the world is too short-term and too focused on immediate nearby returns. And I'm really sorry the woman in the back left, because I was not trying to shut her down, but we can talk about that at lunch. Thank you very much.